So I've kind of told you my story of my health, and now I'm going to get on to my talk. That was the first part I'm going to tell you. I'm going to talk about why we need to do research, and then I'm going to give an actual demonstration of someone of doing how the research can be done very easily. And I hope that you will enjoy this part of the talk. And so I'm going to sit down right here. I've learned that humbleness allows me to sit down. So what is research and why do we want to do it? I mean, we all hear about people saying, well, we got to do some research. And a lot of people have different ideas for it. So what is research in the Touch for Health kinesiology field? What do we actually know right now? And what would be of value if we found it out? So the way I think about research is that research is the careful, patient, systematic study and investigation of touch for health kinesiology undertaken to establish facts or principles that allow us to give more efficient, more effective, and safe interventions in our own self-care and our teaching and the care of others. We don't need to prove by research that what we do works. We all know that. What we need to do is when we're doing research, we need to write down what happens. I don't know if any of you had this happen to you in working with clients or with students and using someone as a demonstration or as a client, and you do something and they say, oh, I feel a lot better, and they come in a month later and they say, you know, that last time you were in, when you were here, you did this for me, and you know right then that they're going to ask you to do exactly that same thing again, and you don't have the slightest idea what you did. All you have down is that they came in and they felt better. Is anybody? Don't raise your hands. But we need to have a way of recording what we do, even if it's in retrospect to doing some careful, patient, clinical studies and reporting these case studies in peer-reviewed journals. Did you know that there is a peer-reviewed kinesiology journal? It is indexed, but I bet none of you have submitted a paper to it. Am I wrong, or is there someone here that submitted a paper to the International Journal of Kinesiological Medicine? Nobody submitted a paper. Oh, back there we have. Richard Utt has. Yeah, thank you, Richard. And it's been published, hasn't it? Yeah, so we do have that. And George Goodhart has, and other people have. Wally Schmidt, you've been published in that, haven't you, Wally? Yeah. But I mean, saying we need much more of that. And they will accept properly done, according to the rules, papers. And individual case studies can be done in a proper way that will let that know. And we will be able to find out, do we have more efficient ways? Can we show better ways of doing things to help people that are safer? So in our health field, field of health enhancement, we're really very, very new. And because we're so new, we're really a bit impoverished. We don't have the advantages of many of the other more established fields of knowledge that are affiliated with colleges, universities, foundations, governments, disease and healthcare organizations. Naturally, these people have a great advantage because they have a long track record. In every new field of knowledge, the pioneers need to make it the necessary sacrifices. We need to make the necessary sacrifices to attract the more conventional sources of funding. This means we must fund our own research first. That's what we have to do. Well, from a scientific standpoint, what does it mean from a scientific standpoint? What do we know? Well, first of all, from a scientific standpoint, we know almost nothing about what we're doing. The criteria of knowledge as far as science is, first of all, it must be public. So how many books do we have that are in the public library? I mean, if you call up your public library and ask for a book on touch for health, a few of them, many of them will say, we've got that, but it's out. But how many other of the kinesiologies have books in the public libraries about our field? That's public knowledge, where everybody can look at it. Peer-reviewed journals is public knowledge. We have a lot of knowledge, but somehow we don't make it enough public. We've got to find ways of making it more public, because that's the first criteria of scientific knowledge, that it is public. Applied Kinesiology has done the best job in our field. That's the Applied Kinesiology journal that I missed. That's the best job that's been done so far. Paul Dennison's Educational Kinesiology has some educational peer-reviewed articles that have been published. And I don't know if anybody else has, but we're moving in those directions. We know what to do, but we need to do even more. So we don't even have the names and addresses of everybody that's doing kinesiology. We don't even have them in our own towns. If I was to ask you, how many people in your town do muscle testing? Would you have an idea? Would you make a guess? Some of you, Maurizio, is saying, yes, I know exactly how many. There are 50 people in town and all 50 do it. Because I've taught them all. All right, we don't know the outcomes of Touch for Health interventions. We don't have them published in peer-reviewed journals at any rate. We don't know what the benefits are in peer-reviewed journals. We don't know how much Touch for Health is placebo. I mean, you know, they say up to 70% of drugs reactions is placebo. Some studies have showed some drugs it's 100% placebo. The placebos get better results than the drugs. We know that in some surgeries they've quit doing them all together because they were all placebo effect. I mean, I read one where they said they used to do a mammillary transplant for angina, and they found out that if they just cut the same place on the chest instead of transplanting the mammary artery, people were better after just the cut than with the mammary artery transplanted. And with other surgeries they found that way. There was recently a placebo study done on the knee for osteoarthritis where they irrigated the knee to wash out the parts, and then they just turned on the irrigation machine, cut the knee, put the knee back together, and they found out 6 weeks later they were equal as far as results were concerned. 100% placebo effect. In fact, the placebo on the knee was better than the actual washing out of the joint. But that's because they're looking at honestly. Medicine is honestly looking at themselves today. They realize, medical people realize, they've got a broken system. The system isn't working. I was listening to a CD yesterday by Marilyn Schlitz, the research vice president for IONS, Institute of Noetic Sciences. I've been a member of IONS now for as long as it's existed. And they are mind-body. And she was saying that those people that are like we are, alternative, complementary medical people, need to look at ourselves as hospice workers for the dying paradigm in medicine. We need to look at ourselves as hospice workers for the dying paradigm in medicine, because the medical profession are trying to do a hell of a good job, and in many cases they are. But nobody likes to read those statistics that have been coming out in the last few years that have said it's dangerous to go to the hospital. You have books being written saying, take an advocate to the hospital. And I know what it's like because, you know, I told you I was in the hospital. And I forgot to tell you one story that gave me quite a lift was, you know, in a hospital, whether you're asleep or awake, they want you to recover, but every 4 hours they wake you up to take your vital signs. I can never figure out, that didn't make any sense to me, but they do. So the day after I had that diagnosis and things that said, you know, you may die right away, this guy came in, I don't know, 2 o'clock in the morning or something, and he comes in bright and says, how you doing? And through the dim light, I looked up there and it was a black man, and in dim light, I said, not very damn good. Doctor just told me I don't have much to live. And just pops out of his mouth, he says, oh, the doctors don't know nothing. Only God knows how long you're going to live. I thought, all right, I like that attitude. So he checks my vital signs, and Carrie says to him, the hospital had supplied a cot, so she was staying in our private room in the hospital. And she said, by the way, what is your name? And he says, Emmanuel. I said, now that's a good sign. That is another upper for me. Now, what else do we need to research? We need to know how much education do you need in touch for health kinesiology to do it safely. Now, I've always said a weekend course you can take in 12 hours, you can learn plenty enough to do it safely. I felt you could read my book and do it safely. I felt you could help people, you can't hurt them. I've asked all over the world, is it dangerous to do muscle testing and rub the reflexes? Nobody's ever told me it was dangerous. There are certain things that are dangerous. Drugs, certain types of drugs are especially dangerous. When you're using heroic medicine, you need somebody who knows what the hell they're doing. Because you can't just stop some of them sometimes. I mean, you stop it, it's worse than never having started it. You got to stop it in the right order. You've got to be very careful about it. You've got to watch for combinations. So we need these highly educated people. The problem is that they're being put into positions that nobody's qualified to do. Like the doctors, when I asked them, how long am I going to live? Their range was 4 days to 5 years. Now, you know that if experts with 8, 10, 12 years of education make a guess 4 days to 5 years, you know they don't have the slightest idea how long you're going to last. But we don't have any idea statistically if anybody has ever been hurt by doing Touch for Health. I don't think they have because nobody sold it to me. But maybe they have. We don't know. We don't know if Touch for Health has a nocebo effect. That's where because of the intervention, you're worse because of the intervention, not because of the therapy, but because of the way the intervention was given. I used to teach in my chiropractic practice. I spent a lot of time with my front desk so that they wouldn't make the patient worse trying to collect the money. Have you ever felt that the doctor was doing really well with you, but when you went out to go there, that you got angry at the person at the front desk? Or when you walked into the place, they didn't greet you, they didn't know who you were, you were there, you've been coming there for 3 months, you've been in there 12 times, and they still don't know who you are? I mean, that's what I call nocebo effect. It makes you worse because you're not cared for. We don't know, as far as Touch for Health is concerned, are there special responders? Do certain types of people respond better to Touch for Health, and some people don't respond as well? Who are the best responders to Touch for Health? I mean, if you were to have 20 people come into you, could you pick out the people that ought to be sent on to a physician for further diagnosis because they're not going to respond well to body work, body-mind work like we do in Touch for Health? We don't know who are the best responders, but we could do some studies on trying to figure that out so we'd be able to not take people's money when they wouldn't be a good responder. Wouldn't that be helpful to everybody? So where do we start? Where do we start? Well, we've got to start locally. And what do I mean by starting locally? I mean, we've got to start with each one of us doing better histories, doing better client-student profiles, doing better records of our intervention. What did we exactly do that helped? I mean, we need to do more monitoring of what is coming out of what we're doing. When you don't want to treat a person because you're going on vacation, because you don't like the way they talk to you, or whatever, what do you do with them? How is the best way to make a referral? Who should the referral be made to? How do we make the referrals? We don't know those things. Well, if we start locally, and then we go on to meeting with groups of people that want to be what I call the Touch for Health kinesiology scientists. Those people are willing to spend the time and effort to be scientists and play by the scientists' rules. There's a whole big set of rules that scientists have. One of the rules that we won't probably want to play by, but we can not play by this one rule, which is if there's not a good logical explanation for why what you do works, we don't want to look at it. Well, we're in deep trouble. We're in deep trouble from a mechanical standpoint because what we do, we don't have really good explanations for. I have a thing that I tell people. What we do is, our assumption is that there is a meridian system. And this assumption is that there is a meridian system, and we have mapped it electronically, chemically, and otherwise, and that is, but it's a little vague because the studies are not all the same. There's a lot of, quote, scientific inconsistencies in the fact that meridians exist, although they've been talked about and used for 5,000 years, and lots of different things say they exist, but as far as actually seeing them and what they do, we say there's a lot of communication. And then we take another big leap. We say not only is there a meridian system that exists, but it relates to muscles. And you can tell whether the meridian system is working good or not good by testing muscles. And you say, well, how does that work? Well, I test the muscle and it's strong, and then it's weak, and I do this waving my hand up and down, or I'm touching these points, and then it gets strong again, and therefore that's scientifically valid. And in one sense it is. It is because we have a hypothesis that muscles relate to meridians, and that by touching the outside of the body and tracing it in certain ways, we will have a certain result. And then we publicly publish that, and other people have taken that information and they have done it over and over and over again, and we've gotten the same results. So duplication of the study makes it scientific. But as far as the reason why it works, the applied kinesiologists have gotten into a wonderful story because they've jumped into the neurological explanation. And they've gone into the neurological explanation of muscle testing and how muscle testing works and with chemistry. And it's a wonderful story. But what it is a story. Because what they're talking about is they're putting a little tiny bit of the substance on your tongue and then testing the muscle. And if the muscle goes weak, they say, that did it. Okay. And they have a neurological explanation that is wonderful. If you love that story, Wally Schmidt does a great job on telling that story. He's talking on this today. I'm giving him a little plug for his talk. He's a great talk, great paper. If you love those kinds of papers, he is terrific. But I'm saying the story. Paul Dennison says, if you do some muscle testing, or now even if the only way you do muscle testing is by having a person get awareness of their body, they see where is the muscle tight and how that is, and then he gives you some exercises to do, and he said, now you're going to learn better. Cool. How does that work? You know, that really makes a whole lot of sense. That's a good story. You're going to do these exercises, and now because you couldn't see a difference between a P and a D, now you're going to be able to see the difference between a P and a D because you had greater awareness. Cool. But the neurological or explanation from a mechanical standpoint kind of stinks. I'm sorry, Paul. Because Paul's work has been adopted by schools not because they have a good story that is really scientifically valid story, but because it works and it duplicates. You can get kids, they actually do read better. They actually do see different things better. They actually do better, and they have changes in their homes. They change from delinquent kids to healthy kids. And I'm saying, wow, that's scientific. But some people won't look at it because there's not a good theoretical hypothesis that has been done, the studies like that. But we don't have them. But we're working in that direction. So we need to look at what we're doing, seeing the results, and develop some hypotheses and some theories about why it does. We've got to have some carefully designed studies that are published in peer-reviewed journals, making them public, and present these methods so that we can help the dying paradigm move in a different direction. Because we have people that are very sincerely, they went into medicine, they went into chiropractic, they went into psychology, they went into all these professions, they put in all these years of study because they want to help people. They want to dedicate their life to helping people. Incidentally, they might make a lot of money, but that's incidental to the fact that why they're in there. But somehow they've had a problem with it, with that. Now, the governments are now looking at this failed model in medicine because of the dangers it has, and they're saying, we got to do something different. The United States government, 11 years ago, started off, because of a congressional mandate, the Office of Complementary and Alternative Medicine. And from this office, with $1 million, it has grown in these 11 years to a full center of complementary and alternative medicine and a $111 million budget in 11 years. That's faster than any other center has ever grown. And we can be part of this research because they're looking for that. Now, what does medicine say complementary and alternative medicine is? See if we fit their definition. They say, anything that the public does to feel better or improve themselves that's not taught in medical school. I mean, we're right there, aren't we? I mean, there isn't a thing that you guys do that's taught in medical school. Well, maybe some things. Now, in the United Kingdom, they had a big national report written, and the House of Commons said, and the report was on the influence of the pharmaceutical industry in healthcare in the United Kingdom. And I want to read you in part. It says, pharmaceutical companies cannot be expected to undertake in-depth research into these areas, which are talking about complementary and alternative medicine. In the absence of other sources of funding, this research must be financed by the government. We recommend that the government fund, quote, multidisciplinary investigations of existing medicines, combinations of medicines, and medicines use where there is relevance in the industry we found where to fund such research. Research also into the adverse effects of medicalization. Research into the adverse effects of medicalization. Trials of non-drug approaches to treatment. There are a number of specific measures which may help focus on health priorities. The World Health Organization has recommended all countries adopt national drug policies to encourage the availability of medicine to all types of patients and the safety and efficacy of these medicines and their rational use. Now, why would they put in there and say rational use if there wasn't irrational use being done? And they're saying that we need to adopt a policy for safety and efficacy of medicines and their rational use to endure medicines that are compared to non-drug approaches. The British government is saying we need to compare medicines and non-drug approaches funded by the government. Our National Health Institute says that we recommend, that's in England, adopt a policy regarding the role of drug treatment in relation to non-drug treatment, emphasizing the importance of both approaches. The United States Government Institutes of Medicine operates under the charter of the Congress of the National Academy of Sciences. David Eisenberg, who's probably done a great deal of helping complementary because he looked at it, but he was written an editorial in alternative therapies in the May-June issue of this year. And his report, he quotes the report saying, the committee believes that research aimed at answering the questions about outcomes of care are crucial in ensuring healthcare professionals are providing evidence-based, comprehensive care that encourages a focus on healing. Evidence-based, comprehensive care that encourages a focus on healing. Recognizes the importance of compassion and caring, emphasizing the centrality of the relationship-based care. Relationship-based care. Is that what we do? Is all of our work relationship-based care? Are you looking at me funny, Earl, because I'm supposed to stop now? Not time to change the tape? Okay, well, I'm just looking. Okay. Stop. 8 minutes more. Okay. So we want to focus on healing, recognize the importance of compassion, caring, emphasizing the centrality of relationship care, encouraging patients to share in the decision-making about therapeutic options. Encourage patients to share in the decision-making of therapeutic option. Promote choices in care that include complementary and alternative medical therapies when appropriate. It also says investigation of CAM, complementary and alternative medicine practices, entails a moral commitment of openness to diverse interpretations of health and healings, a commitment to finding innovative ways of obtaining evidence, and an expansion of the knowledge base relevant and appropriate to medical practice. The recognition of medical pluralism is one way to honor social pluralism. So, we're right there. What we've been advocating, all of the various kinesiologists have been advocating just exactly what this report says we ought to be doing on a national system. We've already been doing it for years. How can we be hospice workers in our communities for this paradigm that wants to change? The paradigm shift sometimes takes 100 years, but all at once it'll be there. And I believe right now we're at the middle of the paradigm shift, and all at once it's going to be gone, and we're in a new model of the mind and body as one, the unity that has been spoken of in all the ancient truths for many years. But we want to remember that it's hazardous to start talking about clinical condition of the patient rather than the person who is presenting themselves to us in a with a clinical condition. I mean, have any of you ever been labeled a cancer victim? Wait, I'm not a victim of anything. I'm a human being. I have not been attacked by something from outside of me. I mean, we hear people talking all the time, oh, they're an arthritic, because they're complaining of joint pain. Oh, they're this or they're that. We name conditions rather than deal with a person on a unique basis. But nearly all of the complementary things that are out there, they say, deal with a person that comes into you, not their diagnosis. The medical profession does that. The problem is that the system with the medicalization and the managed care is that they don't give the doctors time to do that. I mean, how in the world can a chiropractor give personalized care if they're expected to see 100 patients a day? In Italy, that's common practice. Chiropractic, medical doctors refer to the chiropractors that are working for them, and they're expected to make any kind of a living at all. They're expected to give 100 adjustments to 100 different patients a day in the United States. But the funny part about all that is, you'd say, wow, how can anybody do that? They get great results. They get great results, even in spending that little bit of time. And I think one of the reasons why they get great results is they don't do any harm. I mean, it's really hard to put a person in the hospital with an adjustment. But it's easy with an injection. You give the wrong injection at the wrong spot and the wrong drug, it's easy. That's why heroic medicine must be practiced by people that are alert and know what they're doing and keep up to date on all this latest drugs, and they can't only get their information from the pharmaceutical company. We all want to consider not only the person that is being treated, but the context of their life. We all know that family members can have an effect on us. I know that when early in my chiropractic practice I was working with a patient for a low back pain, and they were almost over it. This guy owned a big company in Pasadena, very successful, and his sciatica left, back pain, but he had this nagging little back pain that just didn't want to seem to leave. So I said, let's just see if you've got some other stress in that. So we stressed some, did a muscle test for home, and it stayed fine. Office, it went weak. And then I said, well, let's look at who in your office might be causing it. And I said, think of someone. He went strong, strong, strong. The fourth person came up and he said, went weak. And I said, what about this person? Any stress in that? And he said, I don't know of anything. Well, next time you go back there, just go up and talk to him. See if anything comes up. Next time he came back in, I said, how's the back? And he says, perfect. I haven't had any pain for 3 or 4 days. It's been wonderful, the best I've felt in years. I said, that's great. And I said, what about your friend, at the office I said to talk to? He said, that's the funniest thing. I said, what do you mean? He says, I walked up and I talked to him, and he had a problem that I had the answer to just like that, but he was afraid to ask me for that. And I thought, whoa, this is weird. What kind of an explanation am I going to give for that contextual issue? But since then, I've been working with context. What else is going on in your life right now? When you're having this trouble, what else is happening in you, to look at your contextual issues and look at those things. So we like to balance for goals and look at different aspects of a person's life, and then also look at the contextual things. What else is happening that might be causing just enough to throw them back out of balance, to throw the meridian system off. So we must, as teachers, as practitioners, we must never lose the value, the satisfaction and the excitement of helping individual people to have happier, healthier lives in reaching their goals and fulfilling their missions and destinies. That's the excitement. That's what makes me want to get up in the morning and do what we're doing. I mean, I have gone to doctors and I have the idea that they don't like what they're doing. Have anybody else had that feeling with the people they wonder, I don't like what I'm doing? And I don't blame them, because some of the things that they're stuck in doing isn't really nice. But anyway, I feel like we're so blessed to be doing what we're doing, because people tell you they feel better. I had a woman walk up to me that I'd never seen before and said, I want to thank you for Touch for Health. And she said, my child was dying, 1 year of age, and nobody knew what to do. I learned about Touch for Health, and my son is alive. I say, wow! We have no evidence that that has ever happened before, or even that that's happened, because we don't have a case study on that. But wouldn't it be interesting if we could take a look at that in a clinical study and say, here's what was done, here's what happened, and what other people could be helped? So I'm grateful for all of you and your stories and what's happened and what we ought to be doing. And we need to take a look at what it is. We must first be the yeast, the starter. Then the rise of information will attract others with the financial means to grow this field that we're in. We need to be aware that some of us want to be scientists of Touch for Health. We especially need to be encouraged and recruit those people to use their investigative interests and talents to do the simple research projects. Keeping good records, developing individual case studies that can be published is the task. We need to note here that there is a difference between testimonials and case studies. Testimonials are really important to get. That's what I just had, a wonderful testimonial. It was terrific. It made my heart warm. I'm going to remember that the rest of my life. But it's a testimonial. It's not a clinical case study. But we need clinical case studies on those things. Testimonials are showing of appreciation, gratitude. That is what we need to have. We don't need, it's not an either or. I mean, the scientists say that's a testimonial, like there was something wrong with it. That's crazy. Testimonials are what make your heart warm. I mean, it's what make you want to go to work in the next morning. It's what make you want to teach another Touch for Health class. Those testimonials are the things that, when you get that kind of appreciation, we need those things. We want those things. But it's not either or. It's not one or the other. It's both and. Okay, I want to say that I have enjoyed my time with you tonight. It's been great. I enjoy coming, and when I'm talking and I'm giving talks, I feel better than any other time. So I'm very grateful for you allow me to be at these places and give these talks, and so I want to thank all of you for doing that. I want to thank all of you for doing Touch for Health and other kinesiologies and learning more and being more efficient and helping people and sharing so that we can do a better job for the public. Because our job is to make our world a better place, in a safer place, through things that are cheap. I mean, inexpensive. And compared to what it is, it's just wonderful. So thank you very much, and I hope to see you around for years to come.